Hello, everyone. Thank you for joining us another week and another ResearchWorks episode. Hi, Dana.
Hello, Ash. It's good to be here, huh?
Isn't it?
Oh, pretty exciting because we have an in-person guest today, which is always special when people come into the studio, but even more so because this person ain't from WA. And so we heard that she was going to be in WA and very quickly sent you an email. So welcome, Professor Alicia Spittle. Welcome to WA.
Thank you for having me.
Being here.
Welcome to the studio.
Thank you. It's an amazing space that you have here.
Thank you. It's nice being in a studio where it's a bit more of a controlled environment. It can be a little bit tricky sometimes navigating Zoom links and technology. I think last time we spoke was at the conference. It was really loud and we were just really focused and concentrating. Right. But that was a fantastic episode as well.
It really was.
Yeah, so we spoke not too long ago. For all of our listeners, a bit of a reminder. We spoke about your massive Cochrane review. That was titled Early Developmental Intervention Programs Provided Post-Hospital Discharge to Prevent Motor and Cognitive Impairment in Preterm Infants. And so today we thought, now that we have you here in WA, we thought we'd talk to you about your thoughts on early intervention. Broad topic, I know, but there's the practicalities of providing early intervention within our current context of early detection. That landscape has changed dramatically over the last few years even. And there's been more papers being published on the efficacy of interventions in early intervention as well for children with cerebral palsy. So we thought, let's try to bring all the strands in together a little bit because there's a lot out there.
Sounds great.
Thank you.
And who better to do that with?
Exactly. It's perfect.
Yeah. So as you can tell, Alicia, we're very excited about having this chat with you today. But before we do that, we thought we might remind all of our listeners a little bit about the work that you do. So it's always awkward to sit there while we talk about all the wonderful things you do, but just bear with us, okay?
Just a few minutes.
Alicia is a physiotherapist, clinical researcher, and National Health and Medical Research Council Career Development Fellow within the Melbourne School of Health Sciences at the University of Melbourne. In addition to this, Alicia is also the Associate Dean of Research in the Faculty of Medicine, Dentistry and Health Science, also at the University of Melbourne. Through these capacities, Alicia leads several grants that focus on early detection and early intervention for infants at high risk of neurodevelopmental impairments, including infants born preterm or with cerebral palsy. Not only has Alicia been awarded over $30 million in grant funding and authored over 230 publications, she was also recognised in 2020 as the top Australian researcher in paediatric medicine by the Australian Paper for the highest number of citations from papers published in the last 5 years in the top 20 journals of her field. As a clinician, she works in the neonatal intensive care unit and follow-up clinic at the Royal Women's Hospital in Melbourne, Australia.
I mean, I've heard this one before, but it's amazing still.
Yeah. Thank you.
And when I went onto the website for your profile in the University of Melbourne, I can see all the upcoming grants as well that have been awarded, all the work that's to come as well. So it's exciting to see the space that you're currently in and the work that's you're really driving forward. So, yeah, it's a very exciting conversation.
We'll get into some of that in a minute.
Fabulous.
But after our formal getting to know you, we like to do a little informal getting to know you as well. And that was a sinister laugh, and I didn't mean it to be. So, Alicia, our icebreaker question for today is, what is your secret superpower? One thing that you are weirdly good at?
Oh, thank you. It might seem like a strange superpower, but it's an important superpower for me. I really enjoy running, but I like to run with company. So my secret superpower is when I go travel anywhere, I try and find someone that I can run with. And I have found that person in Western Australia. That's Tash, who some of you might know, who is a physiotherapist and a collaborator in some of the studies that we might talk about today. But I always think my superpower is wherever I run, wherever I travel, I manage to find someone to run with. And I really enjoy it because I often motivate other people to run as well. And I've got another friend who's also a physiotherapist, Colleen Payton, in the US, and she's in Chicago. And when I've gone in Chicago with her, I've got her running, and now she actually just recently did a half marathon inspired by our little runs where I've, as I said, been somewhere and come for a run with me. So that's my superpower.
That's so good.
Travelling, finding someone to run with me, but then hopefully inspiring them to run a bit more as well.
I love that.
That is actually really great.
And what a great way to get to know the place that you're travelling to as well, to be able to navigate that
You do.
on foot. I mean,
See some amazing things.
yeah. I feel like I could use some of your superpowers, Alicia.
And so, are you training for anything at the moment, or is it another marathon coming up?
No,
or?
I did do a 50K run last year, but
my
this year I'm just
goodness.
about enjoying just going for a run. I'm
yes.
actually, I could talk about running for a whole podcast, so I won't go on for too long, but I enjoy doing park runs.
Yeah.
And so I'm going to try and do I'm getting through an alphabet of different locations.
That's so good.
So I was very fortunate in WA because you have lots of park runs.
We
So
do, yeah.
Last time I got myself a U, and this time I got myself a Y.
Oh.
There you go.
That is
WA
so
doing our bit.
clever. That's right. Oh, that's so funny because I love running, but I went through this stage where I was running so much that I was getting really obsessive because you do get,
yes,
it's
absolutely.
very easy to become obsessive and you know your times, you know your landmarks. And then it was just getting a little bit, I just noticed I was just too obsessive. So I was like, okay, I'm going to stop timing myself. But then I kind of would know the song, where I was up to. And so I have my superpower following on from that one, I'm going to change mine.
Yeah. Oh,
Is
okay.
I know the length of a song in relation to landmarks of where I run. And so I know my time and distance. And that was my method of being less obsessive about running and listening to my time or looking at my watch. It was quite a journey just to become a casual runner and just enjoying it without thinking about the time. And that took me quite a while. But in my learning process, I just know exactly how long each song might be, how many kilometers I might be able to, like kilometers per hour I might be able to cut in that time. And I'll know exactly when I'll be back for certain things and where I'll be able to talk to people. And I'm just really good with my time management.
That's amazing.
It is quite a crazy, So when I say to people, I'll be there in, I'll say 15 minutes, but I'll know. Actually, I'll be about 14 minutes and 20 seconds, but I'll know I'll be there. So I can calculate pretty well. It's quite good. But it makes me seem a little bit weird, so I try not to do it. I try to round everything up, round it up to be a bit more acceptable.
Keep a lid on it.
But it is a bit obsessive. Yeah. It's funny how, you can, just these little things can really twig you along. But I'm very good at my time management. If you want me to do something for you, I'll know when I can do it, how to do it. So that's, I think it's a good team player skill. That's how I'm marketing it.
And to music as well.
And to music, that's right. So that could be mine.
I like
Inspired
that.
from Alicia, actually. Yeah.
There you go.
What about yours?
Mine. Well, I've got lots of weird things that I do. I don't know if you would consider them a superpower or not. But I think one of them is I am really good at remembering what seems to be useless information at the time, but then it will come in really handy at some point down the track.
Everyone
so
needs
there'll be
someone like
very
you.
strange things that I remember.
Yes.
And it will come out, say, in a quiz night or, 6 months later, someone will say something at work and be like, oh, I remember this thing that will be really useful for this situation.
That is fantastic.
Yeah. It doesn't come in handy often, but when it does, it's pretty handy.
Look, it's actually that has come in handy a few times when we're talking about who we want to bring onto the podcast and we're thinking about different topics. And I'll say just a single word and you'll be like, there's this person. And I'll be like, how did you not bring that person up earlier? But it took that word to trigger it. So it does, it's like your filing system. Everyone, that's how we access Ash's filing system in her brain.
Yeah, just throw random words at me and something will
see what
stick.
happens. That's a good superpower. Yeah, we've used it many times before.
Yeah.
Good question.
Okay.
Yeah.
So we're going to delve into Alicia's filing system now.
That's right.
Might need a few prompts.
So Alicia, since we last spoke about that huge Cochrane review, can you just give us a bit of an overview about what's, I suppose, changed or progressed in this space for you and an early intervention? I think coming back to, what the topic of the podcast is. Yeah, in the early intervention space, what's really been a standout for you in terms of change or progress?
Yeah, well, we're talking a little bit, Dana and I were talking about this before, but luckily we're now focusing more on implementation. So rather than gathering more evidence, looking at actually how do we implement a lot of this research. And a lot of early intervention, a lot of these studies that were done, say, 5-10 years ago, that they didn't involve people with lived experience in the design. And so often an intervention was tested, but then it actually wasn't implemented because it wasn't feasible. And so I think there's a lot more co-design happening now to make sure that interventions that we're doing are feasible, or if we're trying to implement the intervention, making sure we're involving families in implementing that intervention.
Yes.
So, we have a study at the moment that we've almost finished. It's called Teddy Prem, and it's a randomised controlled trial of an early intervention program using telehealth. And the reason we've done that, again, is to improve accessibility for families as well, because often it's that real challenge from transitioning from the hospital into the community or going home and into the community. And many families feel like we had so much support in the hospital, now there's nothing there. But to travel, particularly from Melbourne, where I'm from, but it's a problem around the world, to travel back to the hospital for intervention is not practical, but it's also not appropriate, and it's not the best use of resources. Families should be supported in the community. But having the telehealth with the clinicians from the hospital helps with that transition. And then when families need it, then they can be linked into the appropriate resources in the community. And then I think the other thing that we're seeing a big change, particularly in the very early intervention, is making sure we target the intervention to the child's needs. So often if we've got a baby, it can be difficult to know what their developmental outcomes are going to be. So what intervention do they need? So we're really trying to focus on those babies who might go on to have cerebral palsy, so the high-risk babies, or early identification of cerebral palsy. So those infants can get cerebral palsy-specific intervention early, whereas the other, say, high-risk children who might be born preterm or have other issues in the neonatal period, they can still get more of a developmentally supportive approach, but not necessarily a rehabilitation kind of approach. So really making sure that we identify those kids early who have specific needs, and then targeting those specific needs, but also including parents in how we implement those interventions.
Yeah, it's so important and so powerful to be able to do that, isn't it? Because it's, we've talked previously about sometimes research happens in a bit of a vacuum, we're trying to control everything we possibly can so that we can really understand what the effect of, an intervention truly is, but that's not how things operate in the real world. So I think it's really nice to see that progress to supporting families, like meeting them where they're at and building, those supports around them. Just on something you touched on in your response there, Alicia, for our listeners, can we just talk about the difference between very early intervention and early intervention, if there's any difference?
Yeah, so there's different things that people call it, but ultra early intervention or very early intervention is starting from when a baby is born. So for someone like me who does still work in a neonatal intensive care unit, it's starting intervention in that, say, neonatal unit. So it might be a preterm baby who, say, is born at 24 weeks gestation, and then looking at what that baby's needs are and when the family is ready very early on. So still when the baby's in the medically stable, but in the neonatal intensive care unit, working with families on early intervention and active early intervention. So getting the families engaged with their baby, looking at what their baby's strengths are, looking at their baby's behavioural cues. So starting really, really early. Whereas traditional early intervention services that we often think of, for example, in Australia, is once a child has a diagnosis for something and then they're referred to that early intervention for specific intervention. So there's different ways that people call it. Some people call it like the neuroprotective approach or versus a neurorehabilitative approach, but really starting very early rather than waiting for deficits or challenges to become apparent.
Yeah, that kind of watch and wait
Exactly.
period that used to be, something that was commonly used. And part of, I suppose, the painting the picture of a diagnosis for these children, which can be quite complex, we know that general movement assessment can make up part of that. Can you walk us through what makes this such a powerful tool in early detection? I find general movements and the concept really fascinating. And I know that you're an expert in this. So, yeah, can you talk us through that?
Sure. So the general movements assessment involves observing a baby's spontaneous general movements. And so we can do it from birth. So it's great for a preterm baby because we can do it with preterm babies in the hospital. But the GMs assess, the GMA has the best predictive validity at around 3 months. So sort of from around 12 weeks to 16 weeks of age, where we look at a type of movement called fidgety movements. And when these movements are present, it's a really good sign of an intact central nervous system. But when we don't see these movements, so we call it absent of fidgety movements, it's strongly associated with cerebral palsy, but it can be related to other developmental issues as well. So it helps us to identify this is a baby that we need to do some more assessments on. And then so if we see a baby who has absent fidgety movements, we'll look at their clinical history, if there's been any neuroimaging, and then if there has, we include those things, but then we also potentially would do a Hine assessment, so the Hammersmith Infant Neurological Examination to put the whole picture together, because unfortunately cerebral palsy is not an easy blood test that we can do. It's a clinical diagnosis, so we have to look at several bits of the puzzle to help us put that picture together. But the good news about the GMs is that we do see these differences in early movement as early as 3 months. And so we can really start intervention very early, whereas it did used to be that we would wait until an infant might not be sitting, walking, and then, as we know, the average age of diagnosis in Australia of cerebral palsy was around 19 months. And so if we're starting intervention then, we've missed out on so much opportunity. So we really want to get intervention starting much earlier. So thinking about when babies first start to reach, to then start to roll, how they engage with their environment, thinking not only about their motor development, but thinking about their cognitive development as well.
And all, like you say, all those beautiful opportunities you have along that developmental pathway to interact and enrich an environment and improve outcomes for them. Have you seen the way that clinicians use general movement assessment? Have you seen a change in that over, say, the last 5-10 years? Is that a space that's changed?
It's changed amazing. Like I could have never envisaged. I fortunately did my training 20 years ago now, and I wasn't the first Australian to do it, but I was one of the first Australians, and I was the first Australian to become a general movements tutor. But when we first used to teach the course, we'd have to really try and convince the audience this is an effective tool, this is what the evidence is. Whereas now, last month I was teaching a course in Melbourne, and it was just, my heart was singing because the group was there was doctors, nurses, allied health, and everyone was there. I always ask at the start of the course, what do you want to get out of the course? And they were like, I want to be able to work with my team to be able to understand what they're talking about. And it was such a lovely group, because it was very much about the multidisciplinary team working together on that early diagnosis, rather than it used to be very siloed, and people were a bit sceptical about observing how an infant moved, whereas I think now we've realised the importance, which we should always do, of observation, and that as clinicians we're trained in observation, and people used to be like, it's very subjective, and it's like, well, no, all of what we do, we're looking at gait, we're looking for a pattern recognition, and that's what the general movements assessment is about. So there's a much more understanding, and then a much more people wanting to learn. So it's more part of standard care now, that people who want to get into paediatrics or are working in the field, like, I've got to do my general movements assessment training. And even if they might not actually do the assessments, they understand the common language and what the what different risk factors, because there are different types of general movements that we look at, where we need to be more concerned versus not so concerned.
Yeah. And so amazing to have so many people now seeing the value that assessment adds to the clinical diagnostic picture. Do you see any challenges to implementing it more broadly than it is currently?
Absolutely, unfortunately. So we, again, almost 10 years ago now, developed an app just as a prototype to help parents take videos of their babies at home. Because at that time, it used to be that the family would need to bring their baby into the hospital. You'd take a video and then upload the video and store it. Whereas parents actually are carrying around a camera. Everyone's got a camera on their phone. Well, maybe we could actually get families to take this. And we've found, surprise, surprise, families can take better photos, videos, I should say, because they can get their baby in the right state. It's very simple what they need to do. And then they're able to upload videos of their babies to a secure server for us to review it. But one of the challenges is, whilst that seems quite simple, in a research context that's okay, but in a clinical context it's quite difficult because different hospitals have different ways that we manage data. And because we can see babies' faces, it's identifiable data. So we, particularly in this day and age, need to make sure that a baby's information is secure. And so it's become a challenge to make sure we've got secure pathways for families to be able to upload videos. And then the other thing, but it is an opportunity as well. So there's lots of people, including our team, working on solutions for that. And then I guess one of the other potentials that we see in the next probably 5 years, and again, it depends who knows how rapidly the world's going to develop around us, is AI. And so the potential for AI to be actually able to not necessarily give the outcome of the video, but give us this baby needs further assessment versus this one's a clear, everything's okay. So if we can get that happening, or even getting more families to be able to upload videos easily, we can then screen more babies. Because at the moment, having every baby come into the hospital is not feasible and not necessary. So I think the advance in technology, we've seen a change in the last 5 years, but I hope that we see a big change in the next 5 years, that there's a much smoother, consistent method for families to upload videos of their babies to be assessed.
Yeah, and really making effective use of clinicians' time as well.
Exactly.
If you've got the ability to raise a flag and then, to guide clinical follow-up, that seems so powerful and an opportunity to make sure that babies aren't falling through the cracks in the system.
Exactly.
This removes those barriers that we know often are the reasons why there might be a delay. It is that, clinician time and being able to get in for an appointment. And as you're talking through all of that, I don't know why I'm skeptical about it, but I always am. The whole 17 years of knowledge translation, it takes that long. You just go, no way. We can make this faster. But that's kind of what you described for general movement. It does take that time, doesn't it? And that consistency, developing the evidence and finding ways to train people. It does take that time.
It does. And I do hope we get quicker and quicker. But it is. But it's interesting because, 20 years ago when I started, if you had said this would be the outcome in 20 years, then that would have been amazing that we had so many people using it, because I was starting off my PhD, and as many people who might have done a PhD, you do a little project and you're not sure how it's going to go. And if you had said, well, actually, it's going to be an assessment that's used by thousands of people throughout not only Australia but the world, and it will become part of standard care, then that is amazing. But I do hope that we can progress more for it to be part of standard care a lot sooner.
That's right.
And it feels like that the barrier of taking the knowledge that we have, implementing into the systems that we work in, that's the biggest sticking point, isn't it?
Yes, exactly.
We've worked in hospital systems before, and you know how complex they are. So any new information or process, it's quite difficult to get it in, and then get the buy-in from everyone to actually be able to pick that up and run with it.
One of the lovely things, though, that we are seeing more and more of, though, is collaboration between researchers. So rather than one place working out how to do it and keeping it to themselves, we're seeing a lot more implementation research, particularly in the early screening for cerebral palsy or early diagnosis of cerebral palsy. There's a lot of implementation studies coming out, but there's a lot of sharing of knowledge as well. So it's not like one group have to work out how to do it. It's like, these are some of the things that have worked. Try it out and adapt it to your practice, but you don't have to reinvent the wheel. And that's been lovely to see that collaboration. And I think over Australia, we're really fortunate that we've got those networks. The US as well. I mean, lots of places around the world that we're actually focusing on not individuals being controlling of things. It's more about gatekeeping. Exactly. It's more about what's best for families and society, and then working out then, okay, how can we make this accessible for everyone? So that's been a lovely shift to see.
Yeah, you can really see that in the last 10 years, I'd say. Yeah. So within this space of early intervention, there's been a lot of new research that has come out, like we just spoke about, and we talk about very early intervention of infants, and we talked about cerebral palsy and high risk of. Can you just help us to maybe walk us through what are the specifics for children who might be at high risk of cerebral palsy? And if there is no diagnosis just yet, what kind of interventions, how does that look, and is that different in that first 12 months?
Yep, yeah, it's a great...
I think we've always lumped it in as one, to be honest,
right.
I feel.
Yeah, and it's... so if we look at the guidelines that have come out in 2017 in JAMA Pediatrics with Iona Novak is the first author, but I'm fortunate to be one of the authors on those guidelines. It looks at, we know there's certain children who might be more at risk of cerebral palsy, children who are born preterm, who've had an event around birth. There's lots of different risk factors. But then to get a label or a classification of being at high risk of cerebral palsy, these can be children who have the general movements assessment is they've got absent general movements, they've got a suboptimal hind, they might have neuroimaging findings, or they might have a clinical history. But it's still, as I said, because it's not an easy diagnosis to make, it still has to be putting that whole picture together and the team saying, can we actually make a definite diagnosis of cerebral palsy? But if we can't, that we can still give the infant a diagnosis or a classification of high risk of cerebral palsy because it's important that they start intervention rather than saying, oh, let's just wait and see. So, in fact, the intervention for those children who get that high risk of cerebral palsy classification based upon those assessments, they should be getting a similar intervention to the children with cerebral palsy.
Sure. Okay.
But what is really important is that those children don't get left with that label of high risk, that they actually, when it's the appropriate time, that they do get a diagnosis of cerebral palsy because there are some, and we've been doing a study recently, there's still some families at 2 years who are still in that category. And look, it might be appropriate, but it might not be as well. And they need families, when it is possible and appropriate, they then need to actually be given the CP diagnosis. But as I said, it's more about making sure that those children can get the intervention that they need early, and it should be then cerebral palsy specific intervention.
Yeah, sure. And what does that intervention ideally look like? I know those guidelines are beautiful, and hopefully everyone can go back and have a look at that as well. But there are some really specific things or ingredients, as we like to talk about them, that we should be thinking about for that group. What would you say are the main ingredients?
Yeah, thanks. And so there's a follow-up paper that we have, which is a systematic review, or a review of the systematic reviews, I should say, that was led by Associate Professor Kathy Morgan. And again, I was fortunate to be part of that group, and it's also published in JAMA Pediatrics. But the key things to take away, the key ingredients is that the child needs to be active in the intervention, and that can happen early. It can happen very early. It can happen, we're actually doing it in the hospital. We can get infants to actively start to control their head, to start to reach for things, to grasp for things, so that they do have the ability to be active very, very early. They need the support, of course, but we can, that's our role as therapists and to teach families as well how to provide that support. So being active very, very early in the intervention, and then being task specific. So making sure that we're talking to families about what the goal is of the intervention, and then actually practicing that particular thing. So if it is starting to reach for a toy, that we get the infant reaching for different toys and think about how we can support that infant, because again, they're not going to be, if we've got a 3-month-old starting to reach, thinking about how can we support their body so that they can reach. So being very active, task specific, and then we need to involve families because it needs to be high dosage of what they're doing. So getting families to do it through play, throughout the day. So we obviously very play-based with our intervention, but not passive, very active. We might need to still give the baby some support, so it's not, completely hands-off. But what we're doing is then trying to work with what the baby can do to get them as active as, so facilitating that active support. And then looking at the environment as well, so thinking about what's in the environment that we can do to help support that infant to achieve things too. So as we know, particularly families in the early days have got a lot to juggle. So even just thinking about, rather than the parent having to be interacting with the bub all the time, how could you set up the environment so that if they're sitting in their bouncer, they've got toys within reach that they can practice reaching. So it's not always the parent having to do exactly doing everything. It's then thinking about how can we set up the environment. So all things that really should be part of our standard practice now for any child with cerebral palsy, but we can start it very early.
Can I just tease apart the word active? Active is one of my favourite words. But I also feel like there could be not different definitions. It's just sometimes taken differently in terms of
interpretations.
I think so. And to me, active just seems like such an obvious word what it means. And I often think about, there's the active as in the child is actively moving towards something. For me, active is also just cognitively active. They're part of the whole thing. Because I've also seen, people say that they're active, but it's also very passive. The interpretation of the word sometimes can be really different. And then there's active as in physical activity. I want the kids moving. I want them to be able to, get that physical activity that starts really early. But can you help us just to kind of go, when we say active, what should it look like?
Yeah, it's a really good question, and I think the same as you, Dana, but I think it's actively participating and actively we know to make those brain connections for the neurons to actually fire together and create synapses. Having someone lift the child's arms not going to do that, they actually have to be getting those neurons to fire to actually make the action happen. So that's sort of how I sort of like to think it's that active control, so that that the brain is the infant's having to, as you say, cognitively be involved, but the muscles then have to fire as well, so to actually make those connections. And so I always like to think about, as a physiotherapist in particular, in that early motor development of we talk about the corticospinal tracts. So for those tracts to develop, you actually have to get, again, those neurons to fire. So I always think from that passive perspective, if I, am picking up a baby and just moving them, that's not going to make those synapses connect.
That's right.
We need to actually get them, the infant actively doing things to make them connect. So it won't always be 100% that the baby's doing things, but if we can help them do some of it, it will help with that. So it's a really important thing, I think, to clarify. And I think it's often hard because people think, the baby can't actively do all those things, but they can actually do a lot actively. It used to, there's been a big change over 100 years that babies used to just be thought of as very passive. And, well, no.
So much more going on.
There's so much more going on.
That's right.
Yeah.
And as you describe in that, I was thinking, it's active and task specificity are two things that need to go hand in hand. Because if it's task specific for a baby, you think about that age, what they should be doing anyway. Like, a 4-month-old baby isn't going to have the postural control to sit on their own anyway. So you might be providing support there. So the task specificity of them being active is within that context as well. So you are providing support, yes, but they're active, cognitively engaged in that activity for that particular task. But it's amazing how sometimes you do need to tease that out, because I think I've just seen it used in different ways. I'm like, is that really active? I'm not sure, in terms of really teasing it out.
And you can see, I suppose, clinicians are often under a lot of pressure with time, the amount of time they have to spend with a family and the resources that they might have. And so you can see how you might fall into the trap of doing a bit more of that kind of hands-on. The baby is a bit more passive, but as a clinician, you feel like you're supporting them to, with that task a little bit more.
Yes.
But actually,
to make it look like it's been achieved as
to
well.
make it look like it's been achieved.
Yeah, that's right.
But actually, when you unpack it, the time is better spent with, not hands off with babies, but, supporting them so it's their brain that's doing the work. I always think about the very first season of the podcast that we did. We spoke to Iona, and that was one of the things that she said, you just need to think about whose brain is doing the work.
Yes, exactly.
And that stuck with me for
stuck
5 years now.
It hasn't gone,
but
hasn't it?
It's
And I think the other thing we have to do is change our frame in terms of we're coaching and helping and guided participation for parents as well. And there is a difference very early on. We're doing more guided guidance with families because they might not necessarily know what to expect. And so we need to be very explicit and tell families why we're doing things as well, because traditionally families probably still expect to bring in their baby to see the physio, and the physio is going to do something with their hands, and they feel a bit ripped off if nothing happened. And so you need to also explain, this is what I'm doing, because in fact you're the parent or the caregiver is the most powerful person in providing these opportunities for brain development, not coming in and seeing me for a session for 2 weeks. But unless you explain that, how are the family to know that? So it's really important that we talk about the importance and why we're doing what we're doing, because that will then motivate the families to go, I'm doing therapy. Or not that we want them to be thinking about therapy all the time, but what I'm doing in terms of play and actually taking that time is actually helping with their brain growth. And in fact, rather than being frustrated about the long waiting lists and my baby's missing out on early intervention,
that's so true.
These are actually the things that you can do now that are so important. And it says everyday activities that are actually going to make the big change. Like if we go back to running, going to run once a week or once a fortnight, so not going to make the difference.
Wishful thinking.
Try that. It doesn't work. But you have to do things every day, and it's not just your running that you're doing; it's the walking and the conditioning and building things up over time. But it's every action, every action is
so
really
true.
important.
Yeah. I always think back of the frontal parietal network. That's so involved in our volitional movement. So when you are initiating a movement, the initiation does happen in the brain. Like you can't see it, and I think being able to explain to parents actually the planning to move is the reason why they should be initiating the movement themselves, cognitively, actively initiating it is so important, because then that's the learning. It's not just the task that you see, but marrying all of that together. And it's great to know we can start that so early, because that is just it's an interpretation, I guess, what you said about babies being a little bit passive. I remember speaking to someone on the podcast, and he was talking about when babies hear and how they interpret. He goes, they just don't give you much back. Like they don't smile at you for quite a while anyway. But there's encoding already happening, and they can see the sound waves. So that's the sign that we need to make sure we're investing in this period. Yeah.
And that's the other interesting thing about the general movements or the general movements, I should say, because it's like, why do babies move? And because they're active movements that the baby's doing, but why are they doing these movements? And it is this whole thing of structure drives function and function drives structure. So it's this, we need to have these movements in the same way that we think, if we just wrap babies up all the time, they're not actually getting to experience that passive movement. So it's important to give babies even just opportunity for free, particularly in the very early weeks and months, just that opportunity for some spontaneous movement. And as we know, babies, they don't intentionally reach for a toy the first time. They accidentally knock the toy, and then they realise they made that movement happen, or they start to develop hand regard, and it's just through that spontaneous play. But you don't realise that they're learning these things until they suddenly then reach for it on purpose. But it's not like they do that for the first time. It's more accidental first, and we know it's that trial and error
and having the opportunity to do that.
And opportunities.
So Alicia, I think I know the answer to this based on what we've just talked about, but coming back to our kind of time and resource poor clinicians, what would you say should be the priority for them in those early months for infants, either at risk or, with a diagnosis of cerebral palsy?
Really working with families and making that time and saying, well, we're going to have our session today. I want you to be involved in that session because we're going to work out what the plan's going to be for the next home program and what kind of things that you can do at home. So really empowering the parents to be able to do things. And so whatever your goals are, and whether you're seeing them in a practice or in the home, but thinking about asking the parents, well, how can we adapt this so that you can do it at home? And what do you think is the best way that we might be able to achieve that goal? Yeah. So really involving them in what they're doing. Yes. Yeah. But particularly early on, if they don't, they might not know what the goal is because it's quite abstract to think about. If they're not sitting, I don't know what to expect. Yeah. So then helping them, okay, if you want to do that, how can we break that down? What are some of the steps that we need to do to get there? Yeah. And really involving the families, empowering the families, and then think about how you make sure that they remember that information as well. So whether it's if it's okay with families, whether they and the clinician, whether they take photos during your session with their phones or whether you just write things down, but just making sure as well that they've got that information accessible for when they go home, because as we all know, it's easy to forget. In the moment, you think you can remember things, but there's a lot people can do. And I think the other important thing, and we hear this all the time from families, that every interaction is really important. So being very positive and focusing on what families can do and being mindful of our language as well is really important too.
Yeah. I love that suggestion of all those additional supports that you can set up for those times where you're not, as a therapist, interacting with the family. 'Cause, you know, especially if we're talking about very early intervention, you've got sleep deprivation, you've got medical complexity, you know, all these things that probably make it really challenging to hold on to that information. And so any ways that you can find to support that family to come back to that information and continue to do that while you're not there, I imagine is gold.
Yeah, and I think parents and caregivers, we've also got to make sure that they're kind to themselves as well, because it can be it's challenging being a parent of a young infant, and let alone a young infant who might have additional challenges and it wasn't what you're expecting, and there's a grieving process and things as well. So just always being mindful that parent wellbeing needs to come first, and so it can be sometimes we don't intend to do it, but as therapists we can maybe think, well, we might be adding to that load because this is another thing that you need to do, that, and parents, this is something else that I haven't got right, and it's very stressful, but really making sure that we reinforce things that are going well, but also the importance of parents looking after themselves too, you know, in the same way that on an aeroplane you've got to put the oxygen mask on first, that they really need to prioritise looking after themselves. And it's okay to get help, and even just thinking about what are your support networks so that you can have that time out, because if you don't have that time out, then it will affect your baby. And often, again, it's a bit of a generalisation, and it is something I have seen change over the years, is families are more aware of their own well-being now compared to 20 years ago when I first started my PhD. I worked with a psychologist, and families weren't interested in looking after themselves. They're much more cognizant now of it's important to look after myself, but we're just really, again, highlighting that look after yourself so that you can look after your baby, because they'll do anything for their baby. But not all. Exactly. But if you don't look after yourself, then you're not going to be able to have that time for your baby.
And so a lot of what you've talked through there, Alicia, you know, in sessions with families, but then also outside of sessions with families, it sounds like to me a really important role for the clinician working with those families is kind of helping to set and manage expectations.
Absolutely.
So, can you just, I suppose, talk through how, I think you've given a few really nice examples, but maybe we could be a bit more explicit and talk through how we can do that kind of gently with families?
Yeah, I think we've always got to have hope as well, and be positive and realistic hope. But I remember an experience when I was talking to a mother that I'd seen her baby very early on, and we were doing a little podcast actually for some educational material 2 years later, and she said that when I first spoke to her about early cerebral palsy, and they knew that their baby was likely to have cerebral palsy, she was thinking about putting in ramps into the house and thinking very long term about things. And her child had a very mild hemiplegia, and so they were always going to walk.
Yeah.
But because we hadn't explicitly spoken about that, there was a lot of stress about things. So I think it's important to talk to families about these are the things that we hope for your baby. And if we do know more about their clinical picture, we know that 2/3 of children with cerebral palsy walk. So even just letting families know what the statistics are is so, well, at the moment, we might not know, but this is what we're hoping for, but this is what we're going to hope for. This is what we're aiming for at the moment. So I think being positive about things and then focusing on what they can do is really important, and then choosing that just right challenge as well, so that the babies continues to achieve things, but also that the family can see that actually this is making a difference, and then being able to progress those things is really important too.
Can I ask on that? That was such a great question, Ash, just to follow on. It's so common, because we are detecting so much earlier, starting intervention so much earlier, it's sort of before that 2 years of age where you generally start to use the GMFM or the GMFCS, then you can kind of see where they might be on the curve.
Yeah.
And so when they're under 2, it's kind of, it can be really hard to know where they might be. And often parents are looking for that kind of information, like you said. They might be thinking, worst case scenario, I need all this equipment in my house. What sort of tools do we have at the moment that can help to direct those kinds of conversations if they're sort of under 2? And because I think that area is advanced more than probably, this other area really.
Yeah, and I for our listeners, as we've talked about, I'm in the studio today, and I've had the fortunate to see around the Healthy Strides Foundation, and it's amazing to see the facilities that you have, particularly focused on those kids who are GMFCS 3, 4 and 5. So it's important that those kids as well get the support early on that they need to, and again, being realistic that if it's not the goal that we're that walking is going to be something that's easily achieved early, that actually we look at making sure that they've got the right intervention very early as well. So one of the best tools for that is the HINE, the Hammersmith Infant Neurological Examination. Okay. And there are cut-offs there that help us guide very early which infants will go on to potentially be GMFCS 1 or 2 versus 3 to 5. Yes. And again, it's working with families and seeing obviously where that child is at, where the family's at, and how clear we are as to whether this does look like it's the diagnosis or not. But also saying, well, we can try these things. They're all going to have a benefit. So do you want to give it a go, or are you not ready to give that a go? So also thinking about with cerebral palsy, it's not just the motor impairment that is for some families or some kids the biggest challenge. It's making sure that if they've got that we're making the most of what cognitive skills that they have and what language skills that they have, and if they can't mobilise to explore the environment, that can have a negative effect on their cognitive and language development. So thinking about, well, how can we make sure that these kids really early on can actually mobilise so that they can interact and explore the environment? And that's where it is really important to have really early gait aids and different ways that these kids can get around.
No, that's good. I like that. Well, we've spoken a lot about, I was going to ask you heaps of questions around implementation, but I feel like you spoke about that really beautifully. Like it feels like we've got it seems obvious, but sometimes it's not obvious enough that we need to really focus on families and set them up. Because I think when you're learning, when you're going through uni sometimes, you'll talk about what's important and the family's important. You know to say that the family's important, but in the context of real life, what's going to translate research into practice is going to be families as the key stakeholder. Like it's their buy-in and their understanding of why we're doing what we're doing. So with all that in mind, what we're going to implement, has there been anything that's come up that's been like a surprise to you in any of the work that you have done already, like all the research you've looked at or the results that have been published lately? Is there anything that's a bit of a standout, like, oh, I didn't expect that, in a good or a bad way, either one?
I think sort of just going back to that supporting of families, and I forgot, Ash, was part of the question you asked me before too, but I think still as maybe particularly with physios, occupational therapists might have a bit more training in it, is actually how to support families because, as you say, exactly that we're told to support the family, but no one actually wants to talk about, I don't know that we always know how to do it. And so with that program that I've been talking about, the Teddy Prem program, the physios and occupational therapists are providing wellbeing support to families, but and doing assessments, but referring to psychologists when need to, but even being able to have those discussions with families to say that it's appropriate to have these concerns, but then knowing when it's appropriate to refer on as well, and just having those general wellbeing tips. And I think that's something that we still struggle with, and I think it's still, I very much respect different professional boundaries, and when families definitely need to go to see the GP or see the psychologist. But there are things that we can do as well, given that families have a lot of things to take in, and just being mindful of actually asking families how they're going and giving them that safe space to say, actually, I'm not doing okay, and just being comfortable with the pause as well and the time that it takes to do that, because as we were talking about before, Ash, people are often busy in clinic and they don't got to go, this is what you need to do. And it's actually just giving that space to say, how are you going? It must be difficult not having any sleep. Have you got much support around? And I think that's something that we can get better at, but we, again, probably need to get the training to do that. And then I think, so there's the other... So that's one sort of part. And then I think the other part is we have got really good at the early detection, but we do need to have those pathways for the early intervention to occur, and for people to feel comfortable providing that early intervention. And in Victoria, we do have very long wait lists for NDIS. And so even if families are having to pay for services or hospitals can only give limited services, really making the use of that valuable time to say, this is what you can do for the next month. These are they might not be doing now, but these are some of the things that we can expect, and set families up.
I love that.
Alicia, I think it would be really nice to end on a note about the future, and I'd love to know, what are you most excited about in the future of early intervention research or practice?
Oh, thank you. I think it is the implementation, because I think we need to we're really, as I said, working together now as collaborative. I'm part of a group called CP360, which has brought three of the biggest CP foundations, so the Cerebral Palsy Foundation, the Cerebral Palsy Alliance, and the International Cerebral Palsy Society, along with other interested people, working together to support early diagnosis and early intervention.
Amazing.
So I think I'm really excited about people collaborating, and then we're trying to make things accessible. So trying to have information on early detection, but then also information on early intervention. And so whether it's just some of the simple things to get started in terms of handouts for family or web-based information, it's not going to replace that face-to-face or other things, but helping get people started. So I'm really excited about people actually working together, because if we work together, we can obviously achieve so much more. So I think that's really exciting to space. So hopefully in 5 years, we've really accelerated that implementation.
That's exciting.
And like you say, collaboration is the key to that, isn't it? Absolutely. Really accelerating, learning from each other and supporting each other in that implementation is really powerful.
We're starting to see those really good outcomes because we're seeing them. Like, in practice, we see them. So we see the effect of an early diagnosis, early intervention and support along the way. And I don't know, I see it here all the time where, that collaboration between different stakeholders is there. And supporting the parents through that journey is such a rewarding part of it, because when you see them on the other side. So one of our other podcast therapists, we've been interviewing families about the F words. And there's a mum that came in recently, was talking about his son's around 2 years old now, and she was like, F words is just the favourite of my life. And she was able to talk through every aspect of the F words to make sure everything is balanced for her. And I thought, that is so good. That is just so great. There's still tough times, but there's still a framework of which they can go, okay, this is what life can look like. This is what I'd like it to be. And this is how I prioritise health and well-being. And everyone needs to have that.
It's really powerful.
Absolutely. And that's like the ultimate, we've done our job when it's the families who are saying that, rather than us saying, this is what people should be doing. That's like the ultimate. You've translated, they know that, and they're empowered. So that's the ultimate goal, and that's amazing.
Absolutely. And having that equity so that it doesn't matter where you are, you get access to that. That'd be a beautiful picture. we'll talk again. I'm sure we'll talk again before the 5 years is up. But
Yes.
let's make sure we catch up about that and
Yes.
go, all right, let's write a gas.
Yeah, absolutely.
Let's measure this along the way.
Sounds good.
Well, Alicia, thank you so much for taking time out of your schedule
Yes.
whilst you're here in Perth to come and see us today at the studio. It was just such a pleasure to speak with you about this area, this space. It's exciting, and I think it just drives me forward to be even more collaborative and to implement. It's amazing.
Yeah.
Thank you.
Oh, thanks so much for having me, and it's been lovely to see where you work and play. So thank you so much for having me.
Yeah, and I spent a lot of time here. Well, to all of our listeners, if you would like to look up some of the work that Alicia's doing, we'll put links on our website so you can have a look, so on researchworks.net. Yep. And stay tuned for so many more episodes. Remember, there's a CPD form there as well you can fill out to keep this as part of a record of your CPD requirements. Yeah. I think I've missed anything. That's it.
We have to say thank you again, Alicia, for being so generous with your time.
Yes.
And thank you to all of our listeners.
Talk to you all again really soon. Bye, everyone.
Bye.